in for a treat today. I'm so delighted that Lisa Cranley is going to be speaking with us. I've had a preliminary exposure to her really interesting research that she has on Huddles because we had an interview earlier. We're doing a series of COVID-19 related talks about great resources, and Dr. Cranley's been doing some wonderfully interesting work. So Dr. Cranley, Lisa, is a registered nurse, and she's an assistant professor with the Bloomberg Faculty of Nursing right here at U of T. She's also an assistant adjunct professor with the Faculty of Nursing at the University of Alberta. And we're absolutely delighted that she also is a non-budgetary cross-appointed member with the Institute of Life Course and Aging. Here at the Faculty of Social Work, and she's cross-appointed as an assistant professor to the Institute of Health Policy Management and Evaluation at the University of Toronto. So you can see that Lisa has many, many hats. And she also, I'm not emphasizing this, but she's got some wonderful doctoral students, and we've even had one of them present earlier this year in our Emerging Scholars series.
And she's here today.
Okay, so Dr. Cranley aims to improve the quality of healthcare delivery to older adults in the long-term care sector. Her research is focused in knowledge translation and decision-making, and she uses quantitative and mixed methods approaches. Her research to facilitate collaborative approaches to decision-making among staff in long-term care, and by engaging residents, their families, and staff together in the team decision-making. And so we're so pleased to have her today. She's talking to us about exactly that, implementing resident and family-led huddles for shared decision-making in long-term care. Thank you, Lisa. The floor is yours.
Great, thanks, Esme. Can everyone hear me okay?
Yes.
Okay. I know there's a bit of a background noise, I think Susan mentioned, from my computer, so I'll try to talk loud over it. But thank you again for the invitation to present this work today. I'm really excited to share the study with you. And as I said, I do research in long-term care and looking at ways to improve residents' quality of life and healthcare delivery in long-term care. So this study in particular is looking at ways to engage the residents and family in huddles in long-term care. My goal, I guess, today is to talk maybe for about 30 minutes or so about the study. I'm hoping to have a discussion afterwards, since this study was interrupted by COVID. So I don't have a lot of findings to present. I can tell you where we left off and our next steps forward. So I can share up to that point, and then maybe we can have a discussion about that after. So, and I'll take some questions after as well. Everyone can see the slides. Is that correct? You can see them as well on your screen?
Yeah, they're good.
Okay, great. So the study is funded by CIHR, and I'm leading the study. Dr. Kathy McGilton is on the study, and she's also a member of the Institute for Life Course and Aging, so some of you may know her. She does research in long-term care, looking at interventions as well. And Dr. Lynn McGillis-Hull is also from the Faculty of Nursing here, and she does a lot of work in nurse staffing. And Wendy Duggleby is from the University of Alberta on the team, and she does a lot of work with quality of life. And our partners, we have Baycrest, the Center for Learning, Research, and Innovation on the study. So we've been so fortunate to have them as partners because they've been doing a lot of the education and leadership coaching that was part of the study intervention. And we have two collaborators, which you're probably familiar with. A lot of you I met earlier before we started are in the long-term care sector. So Samantha Peck from Family Councils of Ontario, and Dee Lender from the Residents Council of Ontario. So that is our team. And I also have some PhD students of mine on the study and some research assistants as well to get some experience working with different types of data. So I'll give you an overview of the study. I'll talk a little bit about the communication tool that we adapted for families' virtual use as well, for virtual huddles. So I'm looking forward to talking about that pivot that we've done for COVID and some next steps. And then, as I mentioned, we'll have some time for discussion and questions as well. So I do have a lot of information here, sorry, so I've taken some notes down, but just some background, again, with the huddles in terms of finding ways to engage residents and family more meaningfully and actively in care planning and decision making was really the goal of this study. And during the literature search I did for this proposal, I found that there was literature on the fact that residents with cognitive impairment may not always be involved with care planning and decisions. Oftentimes staff may have difficulties knowing how to assess their cognitive abilities and capacity for decisions, and they're frail and they're old. As we know, they're our most vulnerable population in long-term care. So oftentimes they're excluded from healthcare decisions, as well as family members. Their participation in decision-making, sometimes they're unclear about their role. It is a standard of care within long-term care homes that families are included, but often the family may not understand their roles or the expectations from staff and what they're able to do, especially now with COVID, but this study started before then. So some of the expectations around their involvement may be unclear, and even with staff as well, staff shortages oftentimes can interrupt some of these meaningful relationships that can be developed with family members. So that's just some background that I've been reading on, and actually recently wrote a short editorial about patient engagement and what that looks like, and how that will look differently now with COVID as well, changing how families visit. So the theoretical framework that was was guiding the study was a shared decision-making framework, and this was developed by Laguerre and colleagues from Canada. And typically, shared decision-making approach in the literature, if you read that literature, it talks about the physician and the patient dyad and how to engage the patient into the decision-making, treatment, and care plan. But this framework I like because they've expanded it to include the family members and licensed and unlicensed care providers, which we know a lot of the personal support workers in long-term care provide the majority of care. So I like that the framework expanded it that way. And it's been used quite a bit in acute care and primary care and other chronic care settings, but not a lot in long-term care. I haven't seen this framework used in the literature, at least anyways. So I thought this could be another goal of the study, to expand this framework into what shared decision-making looks like in long-term care. So lots of different ways we can look at this theoretically. I was thinking shared decision-making then can be one approach to engage residents and family in care. So that's just the background there. So the purpose of the study then was to assess the feasibility of the intervention, to engage residents, their family, and staff. Oh, sorry. In a collaborative approach to care planning and decision making. So we have three broad aims. We wanted to describe the feasibility of the shared decision making intervention. We wanted to describe participants' acceptability of the intervention, so can it be done? And to undertake a preliminary evaluation of participant responses to the Huddle component of the intervention. So we call it the Huddle study, but as I'll describe next, there are actually three components to the intervention, and then the outcomes I'll talk about as well. And some of us were chatting a little bit beforehand that Huddles have been successfully implemented in acute care in hospitals quite a bit around, you'll see patient safety huddles or falls huddles. And they have been implemented in primary care and more recently in long-term care. But the novel aspect of this study is including the residents and the family to actually lead the huddle, so that it's more about what they want to talk about and discuss at that moment, rather than typically huddles in acute care would be around, as I said, patient safety and ways to maybe manage safety and medication management, things like that, but not really including them in that discussion, maybe informing them after. So I wanted to find ways to engage them from the start. Before I did this study, I did conduct some interviews with residents, family, and staff in one long-term care home in Toronto, just to get a sense of what they thought shared decision-making was, and what some approaches and strategies might be to help me to develop this study. And what I found was that there was a lack of communication between personal support workers and the families. Often the families would turn to the nurse rather than the personal support workers who were caring for their loved one. And also found that it was more of a reactive approach in their communication, where there was a concern or something had occurred in perhaps a change in residents' health status that prompted a discussion. So from that, I was thinking of ways to have more proactive communication, where it doesn't necessarily have to be concern, it could be something positive, but just opening that line of communication, that it doesn't always have to be reactive to something that happened, but maybe something more proactive, just to kind of open the lines of communication more frequently. Okay, so it is a two-phase approach. Our first phase, we had developed the communication tool, which I'll get to in a little bit, for the use in the huddles. And then we're implementing and evaluating the intervention. We're using a quasi-experimental study design, but more it's a feasibility study, essentially, aligning with the aims to see if this can be done. So we're in 4 long-term care homes in Toronto, and the studies including leaders and managers, staffs. We have nurses, personal support workers, allies, and we have resident and family dyads who are participating in those huddles. We have 20 staff per home, which was kind of our target intentionally, because our Baycrest partners had provided their educators to come and do an education day with them. So we couldn't include everyone from the home, so we kind of targeted it at 20, since they were covering that cost for them to come for each home. So that is why we have 20 staff. Residents with severe cognitive impairment were excluded from the study just because we want them to be able to participate. So it's an assessment that we make when we get informed consent. But those that are on behavioral units or locked dementia units, we did not include in this study. And the family member, we have them as substitute decision makers just for this study. And we have used family broadly, though, to include friends or neighbors, but they still need to be the substitute decision maker to be involved. We had been recruiting, it's a lot easier when you go into the homes, we had been recruiting through the resident council meetings and family council meetings. So we'll have to do that a little bit differently now moving forward. So I'll just touch on these briefly, and then I'll go through them each in more detail. So these are the intervention components. They are kind of sequential in the way we had done it, but they go hand in hand in terms of informing the huddles. So the leadership coaching focused on selecting quality improvement performance indicators that align with engaging residents and families in care decisions. We had a one-day education training that I just mentioned, put on by the Baycrest educators. We actually went to each site to do this for a full day, which included the leadership team as well. And that was on developing communication skills and engaging families in care. And then the huddles was a strategy to facilitate the collaborative approach to decision making and to have more frequent communication. So we have them scheduled as brief 15-minute meetings led by, as I said, the resident and family member. And it included staff that were trained in the education day. So those were the ones that were coming to practice those skills in the huddles. So not everyone in the building. And then leaders were trained to be huddle coaches to kind of facilitate the process, to keep time and to take notes. So this was, of course, it's going to look a little bit different now, but this was the main components of the intervention. And we had them doing up to 6 huddles, approximately doing these monthly. So the leadership coaching was delivered by Baycrest educators. Each of the 4 sites had one 1-hour leadership coaching session, and we were planning on doing some follow-up 30-minute sessions as well. So I think we can continue with those. So as I said, the leaders selected quality improvement performance indicators that aligned with engaging residents and families in care decisions. So we wanted them to look at their quality improvement plans and select some goals and indicators that they would have to kind of achieve anyways for that year. So how can these huddles fit into that goal of what you are wanting to accomplish for that year? So it's kind of wanting them to align with their goals that they already had and priorities for the home. So it was something that aligned with their quality improvement plans and their leadership vision and priorities for staff performance, which leaders could monitor and encourage while we were there. So the leadership training and coaching is based on relational leadership frameworks and communication tools. And it allows them to simplify their quality improvement plans, enhance team performance, and hopefully an end goal would be to boost practice change if that was their goal. I have to say the Baycrest educators, they're interprofessionally trained educators. They were really great, very well experienced in leadership coaching and just fantastic. So we were lucky to have them to do this component for sure. And they like to use worksheets. So they developed quite a few different worksheets for the leadership coaches, which they found helpful as well. So at this site, their goal was to increase resident participation in programs. So they said that they could do this by involving the residents in the huddles. So there's focused critical behaviors and attitudes to work on that could be contextualized to their setting. And we'd ask them to consider what collaboration looks like for their team. So again, you have to kind of contextualize what they want to work on and how it would align with the huddles. So it's about finding different practices and skills that work for them. So for this particular team, they wanted to build more of the relational team skills. So active listening, effective communication, and collaboration among the team and among family members that come in to visit as well. So that's just an example of some of the worksheets that the leaders were working on for their teams. It's kind of nice too when they come to the education session because then the staff feel supported, that they're all kind of working on this as a goal together. So this was the education training session. But again, the interprofessional educators have done this before at several of the homes. So we selected 4 homes that had not received this learning module before. So the teams learn active listening skills, how to recognize and respond to family concerns using an SBAR team-based communication format for information sharing. And they also develop skills in proactivity, so being proactive, objectivity, so how to kind of report the facts of what's occurring, risk assessment, confidentiality, responsiveness and team collaboration, as well as communication competencies. So the SBAR format, that comes from the military. Actually, I think it was military based in nuclear submarines, but it was a method of communication to report the facts objectively that they could do efficiently. And I think it was also used in the airline industry before it became used in healthcare. So it stands for situation, background, assessment, and recommendations. So staff learn how to apply these skills and SBAR communication to common scenarios of family and staff interaction and to transfer this learning to their daily practice. So the huddles were created then as a way to practice these skills. And for information sharing, because as I mentioned, only 20 staff per home were involved in the education day, so they would need to information share the Huddle information back to the rest of the team for relevant members. So the Huddles then, they can be used to support relational practices and shared decision making and care planning. As I mentioned, they were planned for 15 minutes monthly up to 6 months, and had a practice huddle in there as well. And it included 2 or 3 staff that we wanted to keep them small. So it would be a resident and their family member dyad. So 2 of them would come together with 2 or 3 staff that had attended the education day, and then one of the leaders. So that could be the resident care coordinator or manager from the unit would come to be the Huddle coach. But it's not really about problem solving because there isn't really time in a 15-minute huddle. So it's more about feeling that they're being listened to, and then, as I said, sharing that information back with the rest of the team. So that's kind of the structure and the process that we had set up for them. So the resident and family member have homework. They need to come with a topic beforehand that they wanted to discuss, and they have help with that by our team as well as the staff, because we want them to focus just on one area or it gets to be a bit too long. So they enable them to feel that they are part of the collaborative practice, that they are valued and their needs are considered, and then they can have a chance to clarify their expectations of one another. We also had Huddle training, which originally in this study, I didn't really write in a very big piece. I wrote in a practice huddle, but training became a big part of the Huddles. So it became larger than I had originally planned. So with the help of our Baycrest partners, we actually created a video starring myself and some of the team, our Baycrest partners, as well as we had some volunteer older adult actors from Baycrest on this. It was just a 5-minute video. It was kind of fun to do, but it was showing the process and everyone's role. So we did like a mock huddle that they could use for their training. And we developed that communication tool that I mentioned, which has 5 questions to focus the huddle discussion. So it's something that they complete beforehand and bring it with them, kind of a cheat sheet that they can speak to as a guide. And then, so that's kind of where we left off with the Huddle recruitment. We did do some Huddles before COVID at the sites, and feedback was positive so far, and they found them useful, and they found the training useful. So I think doing this, again, we would do a lot more training as well up front, and write that into the next grant that we do. If we roll this out a bit more, you really need to train them, have that work done up front before they come to the Huddle. So the Huddle tool, so prior to COVID, this was all done in person, we conducted in-person interviews with residents and family members to seek feedback on the Huddle tool in terms of the language and the question phrasing and the content of it, so, and its usability. So they gave us some feedback in terms of rephrasing some of it, and some of the instructions that we had in the preamble that could be clearer. And they shared specific examples of how that could be useful. We had one family member say that it could be useful to help discuss concerns about the provision of nutritional meals at the long-term care home that she was concerned about. So it's just a way to kind of write it all down beforehand to be prepared to talk with staff. So I'll show you the Huddle tool coming up in a couple slides here. This is a slide that Baycrest shares with the teams during the education session. So the first row is showing the family's role in the communication, and then the staff along the bottom there. Just saying that effective communication is supported by clear messaging in appropriate context, followed by confirmed mutual understanding. So the Huddle communication tool was really developed to support this process. And even in light of COVID, mutual understanding and trust has really become even more crucial as we find ways to continue these care conversations between family and staff. So just a bit about the outcome measures, and I promise I'll stop here in a few minutes. As you can see, it's a large study. It was originally planned for 2.5 years. it's gotten a bit off track now, but that's how long it would have taken. So process measures, we had the Huddle coach with a checklist that they completed. We had leadership coaching evaluation and a Huddle acceptability questionnaire that we were having them complete after every Huddle in case we needed to kind of tweak them as we go. Again, it's a feasibility study, so we can make those changes as we go. For outcome measures, we were looking at resident satisfaction with care and their quality of life, and same with family, and we have them complete a proxy version of quality of life for residents. And with staff, we were looking at the quality of their work life. We were never powered in a research